Good morning, and thanks for joining me today. My name is Margaret Wharton, and I am going to speak today on time after time, difference in differences, and interrupted time series models in SAS. And this is part of the work that I do with the Kaiser Permanente Northern California Division of Research. So time after time, why would I call it something like this? Well, these studies designs are based on an outcome of interest. It's a longitudinal design, so we're measuring our outcome over time, and we're looking at changes in this outcome measure over time before and after an interruption. So in most of these designs, we compare both exposed and unexposed study groups, and we also are able to causally interpret these results. So the results that we find, we say, can be caused by the interruption that we're talking about. So there are two different variations on this same idea of measuring before and after. We have difference in differences, or what we call DID, which is where the outcome is measured twice. It's measured in both exposed and unexposed groups, and it's measured once before and once after the interruption. In the interrupted time series model, we actually measure our outcome multiple times. So we measure it multiple times before and after an interruption. And key here is that the measures have to be equally spaced. So we have two sort of variations on the interrupted time series. We have the single group ITS, which is where we only look at the exposed group because they're really the ones we're the most interested in. But there's also a robust version where you use a control group, essentially an unexposed group, to compare to your exposed group to find out if there were changes going on in the background that might explain the difference you saw just in the exposed group, and to account for that. So before and after what? Well, there are different characteristics of the interruptions that we're often interested in. It's an interruption or shock where we know the timing of the interruption. So there's a single interruption. It happens at a known point in time. And generally, these interruptions need to be ones that you hypothesize would have an immediate impact on your outcome. So the outcome changes quickly and systematically after the interruption, and it lasts long enough for you to measure it. Something that makes a blip doesn't really count, and it doesn't work well with these types of models. So some examples would be a planned intervention, say in a healthcare setting, some type of operational change, maybe moving to a new lab test, a natural disaster, and new laws that are enacted. So lots of these studies are done on things like helmet laws or seatbelt laws, that type of thing. So for our example study today, we're going to be talking about insurance benefit changes and patient costs. So we want to control patient healthcare costs. Everybody's been wanting to do that, and employers want to control their costs too. So a lot of employers are moving to offering high deductible plans, which have lower premiums and so cost the employers less. However, when they do this, our patients and their employees increase their out-of-pocket costs. So employers can offset these increased employee costs by maybe passing along part of that lower premium to their employees, but they can also add a value benefit insurance design, or VBID plan. And what VBID plans do are they reduce patient costs for proven effective treatments, preventive measures, and procedures. And the idea is that by putting these plans in and encouraging employees to use these effective treatments, the employees and patients stay healthier, the insurer pays less later, and therefore we can prevent health issues down the line and reduce costs. So the cohort we're going to be talking about today was a cohort of patients in our health plan who had a zero deductible health plan in 2013. In 2014, their employer switched them to a high deductible plan. They didn't have a choice. And all of these members had continuous coverage and continuous drug plan coverage, and were actively taking a medication for a chronic condition like diabetes, hypertension, and high cholesterol. And the VBID pharmacy plan that we also began offering in that year included free medications for chronic conditions like diabetes. So the patients could actually get the most common medications to control these chronic conditions absolutely free. So in 2013, both arms of our study had no VBID coverage. In 2014, both arms of the study were switched to a high deductible plan, and only one of those arms got the VBID benefit. So we had about 1,500 folks with no VBID in 2014 and about 1,000 folks with a VBID in 2014. And we're going to call the people who got the VBID in 2014 VBID even when they didn't have the VBID. So they're the VBID arm of our study, the exposed arm. So basic design, we'd have the two exposure groups, our VBID and no VBID. And the outcome we're interested in looking at is out-of-pocket medication costs for all medications, not just for chronic medications. And we want to see how much this changed from 2013 to 2014, because going on to a higher deductible plan means that drug costs are going to increase. And we wanted to see whether the VBID plan helped mitigate that increase. So our interruption happened on the 1st of January in 2014, where both groups experienced this new high deductible, but only one group got the VBID plan to help them offset costs on their prescriptions. So first we're going to look at this with a DID model, and this is what we call the in Greek slides, where you can see all of the equations and the graphs that sort of explain the equations. So here, beta naught is our intercept term. It's the amount in our example where the amount that the patients would be paying in 2013 who were in the unexposed group, the no VBID group. Beta post indicates the slope of the, or the amount that the total cohort increases between 2013 and 2014. Beta exposed tells you how different the exposed group was from the unexposed group. And in our little graph here, the unexposed group is the blue line, and the exposed group is the dashed red line, and we can see that the exposed group is starting lower than the unexposed group. And then the interaction term tells us the difference in slopes between the exposed and the unexposed groups between our two time points. So one of the things that's important to do when you're doing a DID model is to take a quick look at the raw data. And we can see here that we have the VBID group, which is the red dashed lines, and the no VBID group, which is blue. And it's pretty obvious just looking at this that we've got the VBID group has lowered costs overall. They appear to have a little bit less in the way of variability. You can see the blue lines tend to have much steeper slopes either up or down compared to the red lines in general. And another thing to do with a DID is make sure that the difference that you see in your trajectories between the two study points that you're interested in is not something that had already been going on. So what I did here was I graphed 2012, 2013, and 2014 really quickly. You can see that there's really no difference in the slope between the red and the blue lines between 2012 and 2013, but then at 2013 and 2014 we see some divergence. And so this is an indication that it's a reasonable thing to do to use this for a DID. So should we DID it? We have no sign that those slopes differed between our groups before the study period began, and so DID is likely an appropriate model for this analysis. However, you might want to do some propensity scoring because the covariate distributions may not be equal, and maybe that's what's causing our difference, our baseline difference in costs, why that red line is so much further down than the blue line. And I did actually do the examples here with some weighting. So I did some propensity scores. I'm not including that here, but the code and the results of the propensity scoring are in the paper. So here's an example of what your data should look like for DID modeling. If you look carefully, you'll see that every study ID has 2 rows, and we have a flag for whether the patient or whether the member was VBID or not. Both, for study ID 1004, both of those have an exposed flag because even though they weren't exposed to the VBID in 2013, we're still calling them exposed to differentiate them as a group. And then in post, we have 0 and 1s indicating whether or not this is the post period. So 0 is 2013, 1 is 2014. I have my propensity score average treatment effect weights in a column, and then we have the overall cost for the year that the patient had in out-of-pocket costs. So this rather busy little slide is a quick macro to run the models weighted or unweighted. You can see we're using proc mixed because we have a continuous outcome. And we've got the post and the exposed variables as class variables. The model statement uses the little handy shorthand, the post pipe exposed, to give us post, exposed, and the interaction term. I've requested the solution. And we're using a random intercept model with the study ID as our subject. I'm using unstructured covariance matrix here because we have a large enough sample to do so. Then I have a little weight string macro variable that allows us to put in a weight statement or not. And I've requested the least squares means for all of my variables with the differences in least squares means. And then I'm doing a quick estimate of the DID to give me the values for the actual difference in the slopes. So you can run this macro either weighted or unweighted, and I ran it weighted, and these are the results. So our beta naught, which is our intercept term, is $238.39, which is the mean cost for the medications for the non-VBID group in 2013. The beta exposed is the difference from that in the VBID group. And so our VBID group actually started out paying $73 a year less on average for their medications. Both groups would increase by $38.76 when they move to the non-deductible plan. However, the VBID group actually drops $44.34 in comparison to the no VBID group. So they actually had a slight decrease in costs. And then the least squares means gives us the sort of the averages for these groups. So our no VBID group went from $238 up to $277, whereas our VBID group went from $165 down to $159. So this is an indication that in the VBID group, the VBID itself did actually offset the increase in costs, whereas in the non-VBID group, it did not. So let's move on to the interrupted time series, and this is a figure from a paper by John Adams, who is a biostatistician down in our Southern California group, and this basically indicates when you have two exposure groups in a robust ITS, what the equation is going to look like. So the top line here, we have our unexposed group who are gradually increasing between months 0 and 9. And I didn't put all of the little dots in because these are just least squares regression estimates of all of the different measures. So we have one measure at every time point. And so in the first 9 time periods, we have a gradual increase in both the exposed and unexposed groups. And then you can see at month 9, our interruption point, we have a jump. And the top group actually starts increasing even faster after this jump, and the bottom group decreases after the jump instead. And so all of these betas in here indicate the different sizes of the jumps, differences in starting points, and differences in slopes. So moving on to the equations here, the single ITS is basically only the top section of the illustration. So all we're looking at is a pre-post slope and a jump. And you can get that from this equation with the beta naught through beta 3. And you have it's very similar to the DID, except that you have this beta 2 around the interruption that gives you how much the interruption actually changed sort of the baseline from where it was in period 9 to where it jumped to in period 10. In the robust ITS equation, we put both of these together so that the first row is exactly the same as the single ITS, but then we start adding in all of those same variables for our exposed group. So we have beta 4 exposed, which tells us how different the starting points are. Then we have the exposed times time to give us the slope, exposed times interruption to give us the jump, and then a triple interaction term with exposure, interruption, and time to tell us how different the slopes are between the two groups before and after. So again, it's always useful to take a look at your data in a random sort of way. So I grabbed 30 random study IDs. And for this particular one, we're going to use a slightly smoothed outcome. We're going to look at a 3-month rolling average of medication costs. The reason I'm doing that is because at Kaiser, you can often get a 90 to 100-day refill. And so oftentimes you'll see a jump in 1 month and then 2 months of nothing and a jump in 1 month. So we're using a 30-day rolling average to get our monthly cost and smooth that out a little bit. And again, we can see it looks like maybe these VBID folks are starting out at a lower value, and that there's more variability in our non-VBID folks. So I also plotted the means of these month by month so you can see. And it looks, again, just like the random, there's more variability in our no VBID group, and it looks like the VBID group does tend to be lower overall. So this is the summary picture. There's a little break in here because we took, what I did was I removed a couple of months as the interruption was taking place because we had some difficulties with our pharmacy costs when we first rolled this out, so we figured that we would have a better view of it if we took out that extreme variability in those months in the middle. So here are the data for the single ITS model. We have our study ID, and you can see that each study ID has 18 different measures, 9 before and 9 after. We're starting with month 4 because we're using a 3-month rolling average. And when I label the months gap month, that is actually just the number of months starting with month 1 going up to month 18. You can see month 10 is where the intervention starts, and then on the far right we have the 3-month rolling average for all medication costs. And then down at the bottom you can see we start with the next study ID, starting again with gap month number 1. And so this is the code for the proc mixed again with our single ITS. It's pretty similar to the DID. We have our outcome, we have our month counting variable, we have an intervention flag, and we have the interaction term between the two. Again, I'm asking for the solutions. My repeated statement has my study ID as the subject, and I'm asking for the pre-period slope, the post-period slope, and then the pre-post gap. And note here that the interaction term has the value of 10, meaning the first measure after the gap is month 10 in this particular data. So here are the results from this model. We have our average monthly cost at baseline is $12.67 across the cohort. And of course, again, we're only looking at the VBID folks here because they're the ones who had the interruption that we're interested in. And as we can see sort of from the graph, the cost is kind of drifting up a little bit over time, maybe 8 cents a month. And then we have this big jump of $10.41 at the interruption point, which is offset actually by 10 times the minus 0.99 interaction term. And so what this means is that our overall pre-post gap for these VBID folks is only 63 cents a month. So again, the conclusion we would draw from this single ITS looking just at our VBID folks is that the VBID definitely offset the increase in cost that they would experience due to the change in their deductible. So very simple additions to the data set in order to look at a robust ITS model. We add our exposed and unexposed groups both in here. So our first person is an unexposed member. Again, we've got that count from 1 to 18. And I've put the weights in here as well. So that just adds those 2 columns off to the right. The very bottom you can see is one of the exposed folks who starts out with in month 1. And that's all you need to do is just to add that exposed flag and add your weights if you're using them in order to run the robust ITS model. And so here's the code for that. Again, it's really similar to what we've seen before, at least at the very first. And then we add in all of our exposed group variables times the gap month and the intervention and the triple interaction term. This time I'm weighting them by the ATE weights, which is the average treatment effect weights. Study ID is my repeated subject to study ID. And we run this model and end up with these 8 coefficients. And we can see that on average, when we add in these non-VBID folks into our cohort, the intercept goes up to 18.65. The non-VBID folks with their beta 1 look like they're increasing about 13 cents a month. and that is actually significant, whereas our exposed group, looking at beta 5 with exposed times time, is actually going down by about 9 cents a month, and that is not significant, so it's probably just 0. And once you put all of these different coefficients together, you can generate a figure like this with the estimates that gives, to me, the clearest way of interpreting these results. So we start out with our no VBID group. Our blue line starts at this $18.65 and climbs up to about $19.79 by the time the interruption happens. It's a pretty steady increase. And then after the interruption happens, it looks like their medication costs, they go up, but then they stay relatively stable. We don't see those medication costs increasing again after the jump. In the VBID group, however, we see something that's a little bit different. We see that their initial 9 months, they didn't really increase all that much. They only went from about $12.88 to $13.23 on average. And so they had a jump, maybe not quite as big as the jump in the non-VBID group, but then their costs started going down dramatically. And because we're using a 3-month rolling average, it's probably the reason we're seeing this dramatic decrease is because at first they weren't refilling, and then when they started refilling, those refills got less and less expensive because they were taking these chronic medication. And so basically it tells the same story as we've seen before, that the VBID plan definitely offset and even really decreased the cost of medications for this group. And one of the reasons that it took us a little while to figure this out, why the baseline, why all of our weighting and stuff did not actually change the baselines and make them more similar, is because the factor that is different between the two groups happened to be strong union leadership. And what happened with this group was their union told them all to go home and look in their medicine cabinets and choose every medication that they had in there, and then they asked for that to be put on the VBID list. And so that probably explains why this drop was so dramatic. So that's just a very quick overview of the difference in difference and ITS models. In conclusion, these are really useful study designs, especially for those of us in the healthcare research area. They have a causal interpretation. We can actually say that VBID plan caused their costs to decline. These are really important tools for analyzing the effects of things like operational changes, but also natural experiments and law changes. And the other great thing about this is they're really accessible data sources these days, so you can often use existing administrative data like the electronic health record. You can do retrospective data collection, which really lowers your study costs. And often you can do these studies without involving members of the health plan directly. You can really reduce the overhead and the operational burden of doing these types of studies, and yet still come up with very important results. So I thank you for your attention today. And you're welcome to contact me at this email here anytime with any questions you might have. And I highly encourage you to read the paper, which has far more detail than I was able to present today. Thank you.